I'll be speaking on the management of ulnar collateral ligament injuries. So these are typical PubMed search looking up ulnar collateral ligament, and what you'll notice on this little chart on the side here, this is similar for almost every topic that's been presented today. We have this recent nonlinear growth in publications. You can see there are 121 publications last year. So given our focus format, I want to sort of stick to decision making because I think that's where the hard stuff is for ulnar collateral ligament care. As far as execution of the surgical strategies, biologics or whatnot, Arthrex has made it pretty easy. First thing is, when you try to decide what to do, is who's the patient. Even if we carve out the lower demand patients, even amongst high demand patients, they're going to use their ligaments very differently, and you have to think about the functional demand. You can see on the left here, you have someone that's going to load with high to sometimes catastrophic loads with the elbow and extension, and some people who will want to use the ligament in a different fashion with elbow more in flexion with high volumes of throwing. Now, what is the injury? Back in 1946, Juarez asked a simple question that we're still asking today. Is this a trauma or is this continuous wear and tear? Because again, if it's a trauma of good tissue, we're thinking it might be able to heal, this is something we might be able to repair, or is it completely worn out and do we have to replace it? And over the years, that was a javelin study. Over the years, baseball sort of taken sort of the center point for ulnar collateral ligament injuries. This is where we see most of them. And ultimately, we sort of ended up with our current paradigm, which sort of looks like this. You've got repetitive elbow valgus loading. Eventually, this leads to ulnar collateral ligament insufficiency. And ultimately, we've learned a lot about the posterior medial osseous compensation and that reciprocity. So when it comes to how to manage the injury, what's the actual injury, it really depends where in that progression where you catch your patients. Because again, with throwing, we know that the disease can progress asymptomatically for a very long time. And with a younger thrower like this, you may see good tissue with a traumatic avulsion. Now, for over 40 years now, the bread and butter gold standard for ulnar collateral ligament injuries has been Tommy John surgery. And even though it took a couple years to get Tommy John back, it led to another 164 wins. And since then, as with any other successful surgery, you have numerous iterations, modifications of approaches, different ways to put the graft in and dock it. And there's a very wide variety of reported success, anywhere between 70 and 95%. Now, if you look at the studies that come out in the 90s, the success rates were really high. And because at the time, the metrics that we were using were return to play. Return to play meaning you threw one pitch and you got back. Nowadays, we're looking at things like workload, performance metrics, and the success rates have dropped to sort of in the middle of that range, of that 75 to 80%. The other thing that's changed is the timeline. This becomes really important for decision making because timelines used to be quoted as a year. Now it's pushing more like a year and a half for a professional thrower. We always use SOS, and this is something I always track as a visual analog scale. Rob Keller, one of our fellows, published a nice study looking at this. So we looked specifically at medial elbow pain following Tommy John surgery and found that those that had medial elbow pain during the progression back to throwing, maybe they're throwing too early or too aggressively, had a significantly increased risk of a secondary surgery. So it's nice to be able to track that. Obviously, with SOS, we can also follow outcome scores, things like the SANE score, which is great for our payers and for research. Now, traditionally, non-surgical management has been considered suboptimal, but in the last 10, 15 years, there have been huge increases in our knowledge about rehabilitation, kinetic chain management, and we're starting to see the fruits of that labor. In Frangemore's study here, 66% return to same level of play and up to 81% with return to same level of play and a proximal injury. So again, if you're looking at indications for non-surgical management, think proximal, not distal. This was reproduced in Ford's study out of Tom Noonan's group, 84% return of same level of play with incomplete tears. And again, in their group as well, distal tears did work. So for non-operative management, I tend to shy away for distal tears. Now, Buddy Savoy quietly published 2 repair studies in the midst of that PRP excitement, and what he found was this. Again, we're going to look at the details. These are primary suture anchor repairs for proximal and distal avulsions. And he had 93% good to excellent results. In a follow-up study that he did in female athletes, 17 of 19 returned with repair only. So again, what are we looking for in the primary repair group? Avulsion type injuries, again, more trauma than wear and tear, non-throwers, and younger athletes. Jeff Dugas took this a little bit further and added an internal brace. This is something that we've been doing for a long time now with internal bracing, and the elbow is a great place to do it. He's done 2 studies, this one in AJSM and one in OJSM, showing that the biomechanics of this construct are very robust. So again, it's like a suture anchor repair. Let's say you've got a proximal tear, you do a suture anchor repair with essentially a swivel lock proximally, and then you span it with an internal brace distally. So you can do that flipped in reverse. You can have a distal tear, repair it distally, and swing your IB up proximally. And at least in presentation, we're still waiting for publications, at least in a presentation format, we've seen return to same level of play north of 90% in his cohort, as well as in George Paletta's and others. So when it comes to management, I sort of think about it as 3 buckets. You're going to do one of 3 things. You're going to do repair with or without internal brace. You've got non-operative management with or without biologics, and you've got reconstruction. So what I like to do is sort of go through the questions who, what, when, and why. So who's the patient, what's the athlete, what do they need to do with their arm, and what are their prospects. That's sort of the macro lens or the first gate. Then we go into the details here, the micro lens. What's the injury? What's the nature of the tissue? Is there a lot of tissue attenuation? Where is the injury? Is it proximal, mid-substance, or distal? And then finally, this one becomes even more important, is when and why, because timeline management is critical. Again, repairs maybe 6-9 months out, non-op maybe 3-4 months out, reconstruction maybe north of 1.5 years sometimes. So when is very important. A thrower that's injured in the spring versus in the fall is very different, and then why. If you take someone at the last year of their throwing career, be it high school, college, professional, that's going to take ulnar collateral ligament reconstruction probably out of the picture. So this is where I think we're heading in the next couple of years. Initially, this has been all green, right? Tommy John surgery for everything that fails non-operative management for most part. And we saw an Erickson study back in 2015 during this Tommy John surgery epidemic that the peak age was age 15. So, that's probably not what we should be doing is Tommy John surgery in 15-year-olds. Hopefully over the next few years, we're going to get better results, more published data to support doing more advanced non-operative management and UCL repairs. There's a 35-year-old male competitive powerlifter, felt a pop and pain during heavy snatch. Again, that's arm and extension. Given that he's competitive, he's probably looking to get back to that same level of play, but he's got this proximal avulsion. The tissue overall looks pretty good. He's not doing it for a living, so he has time to be conservative. 3 months, PRP, he fails the biologics, he fails the time down, so he gets an ulnar collateral ligament repair with internal brace and is able to go back to competition. And the last one here, here's more of the classic case that you've seen presented for years. 24-year-old major league pitcher, comes in out of spring with some medial elbow pain. Obviously, you look at that ligament, you go, okay, this thing's pretty beat up. He's got a lot of tissue integrity issues. He's got an acute on chronic proximal avulsion. And so he gets PRP because it's mid-season. He's able to go back, but his control's poor, his ball velocity is down. So at the end of the season, he gets Tommy John surgery. So in conclusion, we want to look at the pros and cons of all treatment options, particularly timeline. Again, you're managing timeline, so know how long these things take to get back. Non-operative management, we're pretty liberal with biologics in addition to rehab techniques. From a repair standpoint, I typically will put internal brace in all of these. I don't see that there's a tremendous downside. And remember, again, for UCL repairs, they're choosing a repair because they want to get back sooner, so you know that they're going to load your repair a lot sooner than not, so it's better to put something there to splint it. And then, of course, UCL reconstruction. As far as refining the indications, just go through the questions. Who's patient? What's the tissue quality? Where's the injury? When? What's the timeline management? And what's the investment level? Remember, again, not everybody needs surgery. They might be the end of their baseball career at any level, so we don't want to put them through a very big surgery if they're not going to get back anyway. Thank you.